Welcome to this part of the presentation, which is on gut discomfort in toddlers. Trying to give an answer to the question, can nutrition bring a solution? This is my slide with possible conflict of interest, and we'll move to the layout of the presentation. After a short introduction, we will focus on functional constipation and functional diarrhea, and then come to conclusions. Functional gastrointestinal disorders in toddlers, they have been defined by the ROM4 criteria, and they are known to be very common worldwide. So we focus on this presentation on the age between 1 year and 3 years, because that's what toddlers are. And then you will see that it's mainly functional constipation and functional diarrhea, as illustrated on the next slide, showing you the range of these conditions according to literature. Functional constipation occurring in 3 up to 27% of all the children, and functional diarrhea occurring in 6 to 7%. You may have noticed that at this age there is also cyclic vomiting syndrome, but that's much more rare, and so we will not discuss cyclic vomiting syndrome. Abdominal pain is very frequent in toddlers, as said before. So what are the known causes and risk factors? The pathogenesis of functional pain syndromes involves their interrelationship between changes in visceral sensation and altered gastrointestinal motility. So the pathophysiologic mechanism for functional abdominal pain include visceral hypersensitivity and abnormal gastrointestinal motility, causing inflammation of the intestinal mucosa and altered intestinal barrier functions. Altered microbiota plays an important role. Post-infections immune response is important, and altered functioning of the brain-gut axis are all major players into the development of the abdominal pain. And there are, of course, predisposing factors for functional abdominal pain, but going into depth of those predisposing factors would take us too far away. How frequent is functional abdominal pain in children? Well, worldwide, it's about in 15% of all the children, as you can see illustrated on the picture below on this slide. And did it change a lot over time? Well, in fact, not so much, because Apley and Nash were the first to focus on the importance of functional abdominal pain in children almost 60 years ago, and they reported that it occurred in 11% of all the children. So the incidences reported today are not so different from the incidences reported 60 years ago. The major problem with functional abdominal pain in children is that it occurs in more than 10% of the toddlers, but that an organic cause is very rare, luckily, but that makes the management difficult. And organic causes occurring in less than 10% of all those children with functional abdominal pain. Also important to realize is that whenever a toddler develops functional abdominal pain, that will have consequences on the quality of life for the toddler, but also for the family, and consequences for the quality of life at the moment itself, but also later in life. So functional disorders do have long-term consequences for the family, decreasing quality of life, but it makes the patient, the child itself, also at risk for other functional gastrointestinal disorders later in life. These data from Italy focus on children with functional gastrointestinal disorders at the age of 8 years. And when you go back in history and you look for the incidence of those children of infantile colic, regurgitation of functional constipation, then you see that during infancy, those functional disorders were 2 to 3 times more frequent in children who have abdominal pain at the age of 8 years. So early life functional gastrointestinal disorders predispose to functional gastrointestinal disorders later in life. So what do we know about functional constipation? Again, let us focus at the age we are interested in during this presentation, which is between 1 and 3 years. And the peak incidence of functional constipation is between 2 and 4 years of age, when potty training is started. And so the median age of functional constipation onset is 2.3 years. But important to realize is also that it takes long delays, measured in years, between the age of onset and referral to a pediatric gastroenterologist. So diagnosis of functional constipation is made often much later than the onset of symptoms. So we should focus much more on the onset of symptoms. According to these relatively new data published this year on the prevalence of functional gastrointestinal disorders in European toddlers, we found that the most common disorders in toddlers is functional constipation, again occurring in 10% of all the toddlers. Thus, figure between 10 and 15% comes back all the time. So how should we manage functional constipation in infants and toddlers? The first step is disimpaction, bowel emptying, which will take 1 to 3 days. And the second step is maintenance to restore muscle tone and allow the gut to return to its normal size. And their dietary instructions are very important, and they need to be continued for at least 2 months. And the third step is maintenance to restore regular bowel movements. And again, there, dietary measurements, increasing fiber and fluid intake are very important, and they should be continued for at least 4 to 6 months. So what do we know about fiber, fluid, and physical activity? Well, based on expert opinion, according to the ESPGHAN-NASPGHAN guidelines, which were published now some 6 years ago, we recommend a normal fiber intake, a normal fluid intake, and a normal physical activity in children with constipation. Now, most of those children do not drink enough, they do not eat enough fibers, they have a low physical activity, so it should be brought back to normal levels. What about the use of probiotics in the management of functional constipation? Well, this is a study from Japan in which Lactobacillus reuteri DSM-17938 was compared to magnesium oxide, and magnesium is a well-known effective laxative. The conclusion was that in toddlers, Lactobacillus reuteri and magnesium oxide were both equally effective in the management of constipation. Other data on the same Lactobacillus reuteri in children with functional abdominal pain, showing you that for the number of days without pain and the severity of the pain, Lactobacillus reuteri significantly reduced the number of days and the severity of pain compared to placebo. And that already after 2 months of administration. So Lactobacillus reuteri has multiple probiotic properties. It modulates the composition of the microbiota, it adheres to the intestinal epithelium, it produces metabolites which have health-promoting benefits, it stimulates neuromodulation of the enteric nervous system, it modulates the immune and inflammatory responses, and it results in an enhanced mucosal barrier function. What about prebiotics and their role in gut comfort and health? Well, there are several prebiotics. Most of them, the ones which are best studied are galacto-oligosaccharides and fructo-oligosaccharides, and inulin is also well known. So these prebiotic GOS and FOS, they result in a gut microbiota modulation closer to that of breastfed infants. They have thus a bifidogenic effect. They change the metabolic gut activity by decreasing the stool pH, which limits the growth of pathogenic bacteria. But of interest for our presentation, they increase the stool frequency and decrease the stool consistency, which is of benefit in the management of constipation. So which data do we have with FOS and GOS in constipated infants and toddlers? Well, this looks at control infant formula showing that 7.5% of the infants do present with hard stools. That in breastfed infants, it's only 0.6% with hard stools. And infant formula supplemented with GOS and FOS, it's 0.7. Exactly the same incidence of hard stool than in breastfed babies. And of course, significantly lower than in infants fed non-supplemented formula. So what do we know about GOS, FOS, FOS inulin, and FOS alone to support a healthy gut microbiota? For GOS and FOS combination, they have been shown to promote soft stools. FOS and inulin combination promotes soft stools and increase stool frequency. And FOS alone promotes soft stools, reduce the risk of constipation, reduce the risk of diarrhea, reduce the duration of diarrhea. Which clinical studies have been performed with partially hydrolyzed protein versus stool characteristics, efficacy of partially hydrolyzed protein in the management of constipation? So a number of studies have been performed, and the number of studies showing a positive effect out of the total number of studies is for stool frequency improvement 2 out of 4, and for stool consistency improvement 6 out of 9. So partially hydrolyzed protein is effective in the management of functional constipation in toddlers. A few words about functional diarrhea. Functional diarrhea was previously called toddler's diarrhea. It's mainly caused by a low-fat diet, unbalanced diet, or no cause at all. And lactose intolerance is often mixed as a cause with functional diarrhea, although it's quite different. So what do we know about dietary carbohydrates in functional gastrointestinal disorders is that some individual carbohydrates or combination of carbohydrates, when they are ingested too much in too large amount, they can cause chronic functional diarrhea, resulting in diarrhea, bloating, and as a consequence of that, pain and gassiness. How frequent is it? Well, it's illustrated on this slide, going from relatively rare in Scandinavian countries to about 100% of lactose intolerance in Chinese population. But of course, it does hardly exist in infants, and in children aged 1 to 5 years, the primary lactose intolerance ranges from 0 to 18%. So how to manage it? In secondary lactose hypolactasia, lactose intolerance, a restricted diet will result in normalization of the lactase activity, and so restricted diet is needed only for short time. In primary lactose intolerance,